I appreciate the opportunity to present this topic. And so what I'm going to be talking about is a general overview of some of the mutations that we find in non-Hodgkin lymphoma and how we're trying to incorporate those findings into therapy. And a lot of this will be touched on by subsequent speakers in more detail. So we can use diffuse large B-cell lymphoma as an example that raises a key question that can be applied to most types of lymphoma. And that is, what explains the heterogeneous outcomes that we observe in response to a given therapy? So the graph here illustrates the responses of patients with diffuse large B-cell to R-CHOP chemotherapy in data that was compiled by GILA. And as you're well aware, approximately half of patients with DLBCL are cured with upfront R-CHOP chemotherapy, whereas the other half of patients don't fare as well, some exhibiting transient responses and others that are completely refractory to the therapy. So one of the overarching questions in lymphoma research has been, what are the molecular features that distinguish patients that do well in response to a therapy from those that don't do well? And a seminal observation for DLBCL was made in the year 2000 when the group at the NCI performed gene expression profiling on a large cohort of diffuse large B-cell lymphomas. So many of you are probably aware of this data, but the gene expression profiling identified that DLBCL didn't appear to be actually one disease, but there were distinct molecular entities within it that were characterized by unique gene expression profiles. There was a germinal center B-cell-like subset and an activated B-cell-like subset, and I won't talk about some other subsets that were also found. But basically, these two subsets had gene expression profiles that mirrored normal B-cells that were undergoing different stages of germinal center B-cell differentiation. The GCB subset appeared to arise from an earlier stage of differentiation, whereas the ABC subset appeared to arise from a later stage of germinal center differentiation. And the reason why I'm mentioning this is because there was the important finding that when you segregated patients with DLBCL based on this cell of origin classification, they found that basically the GCB subset did very well in response to R-CHOP chemotherapy, whereas the ABC subset accounted for most of the patients that did poorly in response to that. So this was really the first a demonstration through modern molecular techniques that within a given histology of lymphoma, there were distinct molecular entities and that these had important relevance for determining outcome in response to treatment. However, back then, this is still largely a descriptive and phenotypic finding, and it was unclear what aspects of these molecular features could be targeted to improve treatment, particularly for this ABC subset that does poorly. So over the ensuing years, continued scientific advances revealed more of the molecular underpinnings of DLBCL, and this same sort of progression was followed in other types of lymphoma as well. So really, as I told you, we moved from a histologic classification to these initial gene expression profiling studies that identified distinct molecular subtypes. From there, copy number analyses were performed that could identify genes that were either lost or gained in different types of lymphoma. And these typically genes that were lost were identified as tumor suppressors, whereas genes that were gained were identified as oncogenic drivers, suggesting that they might be targeted therapeutically. In the mid and late 2000s, there was advances in RNAi technology such that investigators could perform unbiased screens where you knock down thousands of different genes in lymphoma lines and identify genes that are critical for lymphoma cell survival. Those genes that were identified in these screens were sequenced, and a handful of mutations were found that appeared to activate oncogenic pathways important for lymphoma cell survival. But really, from this point on, up to around 2010, all these advances identified just a handful of mutated genes that were important for driving lymphoma. But really, in the past 5 years, whole exome and whole genome sequencing has provided the opportunity to have an unbiased and comprehensive assessment of the mutational landscape in lymphomas. So when whole genome, whole exome sequencing was performed on diffuse large B-cell lymphoma, the most striking finding was the remarkable genomic heterogeneity in the disease. So there were mutations and genomic alterations found in over 300 different genes, But the most notable finding was that none of them were pathognomonic for the disease. All of them occurred at less than 30% frequency, and most were well under 10% frequency. So this is a graph from one of the papers from the Dalla Favera group that sequenced a large cohort of DLBCL. And on the x-axis are individual genes, and the y-axis shows the percent of cases that harbor mutations in that gene. And as you can see, there's really only a handful of genes that are in over 10% of cases, whereas there's this long tail of more rare mutations that occur a handful of times. So how do we make sense of this data? One way to do that is to group the sets of genes into biologic categories that that we know are important in lymphoma cell survival. So in DLBCL, one of the most commonly mutated pathways involved signaling through the B cell receptor and NF-kappa B signaling pathways. So normal B cells depend on signals through the B cell receptor and other co-stimulatory receptors that have a cascade of signaling that culminates in activation of NF-kappa B, and this is critical for B cell survival and proliferation. What was observed in the sequencing efforts was that there were frequent mutations that activated positive regulators of the pathway or inactivated negative regulators of the pathway. And this included the CD79A, which is a component of the B cell receptor itself, downstream adapter molecules such as CARD11, and then other adapter molecules from co-stimulatory receptors such as MyD88, and then inactivating mutations in negative regulators such as A20 or TNF-AIP3. So the net biologic effect of these mutations was that they promote constitutive activation of these signaling pathways that promote B cell survival and proliferation. And it became immediately obvious that there were therapies that were being used for other indications without the knowledge of the genomics that target some of these players, and that there are also many agents under investigation that could also potentially target it. So I should state at the outset, there's no actual FDA-approved indication for a therapy that targets any specific genomic alteration in lymphoma, but I'll be talking to you about how we're trying to translate these genomic findings into clinical trials to test some of these hypotheses. So we knew that, the drug ibrutinib targets upstream kinase BTK in the BCR signaling pathway. Lenalidomide targets some of the downstream pathways. And then investigational agents such as SYK inhibitors, BCL6 inhibitors, and MALT inhibitors might hit these targets. And what was notable about the mutations in this pathway, which I want to emphasize again, is that this is one of the few cases where there was a segregation of the mutations such that they were more common in this ABC DLBCL subtype. So another biologic pathway that was very commonly mutated was genes involved in chromatin modification. So there's a whole set of enzymes that are involved in basically toggling chromatin from a transcriptionally active state to a transcriptionally inactive state. And these involve enzymes such as EZH2, which promotes methylation that drives this repressive state, and enzymes such as MLL, which drive histone methylation that opens up chromatin, and then these histone acetyltransferases that also promote histone acetylation and active transcription. The balance of this active and closed chromatin is important for B cell development, and particularly in the germinal center. And what was observed was that there were a variety of mutations in these enzymes, which the net effect was to drive the chromatin state into this repressed environment. And that has been shown to lock B cells in this aberrant differentiation state where they can't exit from the germinal center, as well as silence tumor suppressors. So when you think about potential ways to target these pathways, we have been using histone deacetylase inhibitors for many years in lymphoma, and it might be possible to then find patients with these alterations and use those. There's investigational agent, and I should say that Dr. Batlevi will discuss this more in the next presentation. And then there's investigational agents such as EZH2 inhibitor, which can inhibit the activity of this enzyme, which is activated in lymphoma. And Dr. Gerasitano is running a trial here investigating that question. Another major category of genes that are mutated in DLBCL were genes involved in immune recognition. So there's loss of genes that are critical for presenting antigen to cytotoxic T cells and NK cells, and that includes the HLA molecules, beta-2M and CD58. And then there is also amplification of inhibitory receptors that can shield the lymphoma cells from immune recognition. So this raises the question whether in these cases could we relieve that inhibitory receptor blockade using checkpoint inhibitors, or bypass the need for normal antigen presentation by using therapies such as CAR T cells. So in addition to DLBCL, there's been extensive genomic profiling of a lot of the major subtypes of non-Hodgkin lymphoma. And each of them exhibits dozens of different mutations. A lot of these mutations overlap between histologies, but some exhibit a relative preference for the different types of lymphoma. And I'll just go through an example for each of these that can be targeted potentially by therapies that have been investigated here at MSKCC or elsewhere. As Dr. Dogan mentioned, follicular lymphoma is characterized by loss of this TNF receptor, which is important for regulating B and T cell interactions. And work by Guido Wendell here at MSK has recently shown that you can deliver this molecule back in a soluble or secreted form and then have a dramatic effect on the follicular lymphoma. Marginal zone lymphomas, in particular splenic marginal zone lymphoma, are characterized by very frequent mutations in the Notch pathway, and the Notch pathway inhibitors have been under investigation for many years in a variety of cancers. SLL and CLL are characterized by mutations in splicing factors such as SF3B1, and Dr. Abdel Wahab will talk about how these pathways can be targeted by splicing factor inhibitors. I already spoke to you about DLBCL and some of the implications there. Here I'm mentioning the translocation in cyclin D1 in mantle cell lymphoma, which there's active investigation of using CDK4/6 inhibitors to target that alteration. In Burkitt lymphoma, the group at the NCI identified mutations in ID3 and TCF3, which were shown to activate the PI3 kinase signaling pathway and potentially make these lymphomas susceptible to inhibition there. In T-cell lymphoma, activating mutations in CD28 are found in PTCL-NOS, and these can be targeted in preclinical models by using NF-kappa B pathway inhibitors. IDH2 mutations are found in AITL, and Dr. Horowitz will talk to you about using mutant IDH inhibitors in that disease. In anaplastic large cell lymphoma, there's recurrent mutations in the JAK-STAT signaling pathway, and those can be targeted by JAK inhibitors. So all these findings were made in the research setting, and the big question is, how can we translate these into the clinical setting, identify these mutations in clinical specimens, and then apply these in clinical trials to know if they can be targeted therapeutically. And I'm not going to go through this in detail because Dr. Arcila already did a great job of this, but the approach that we've used here, and a lot of people have used to apply this to the clinical setting, is this targeted hybrid capture technique, where basically you can have a panel of 400 genes or so, as Dr. Arcila mentioned, and you can focus your sequencing on those. And basically you generate lots of reads in those genes, and you can identify point mutations, small deletions or insertions, copy number deletions, copy number gains, and translocations, as she described. And the advantages of this technique is that it really eliminates the tissue requirements that you need for whole genome and whole exome sequencing. And now it can be applied to our typical lymphoma clinical specimens, which are FFPE. We can use a small amount of material and have a high depth of coverage that can capture mutations and all those variants that I told you about. And the analysis is streamlined because we're really focusing only on genes that we found to be relevant in lymphoma, and they can be modified as she told you. So we're really, at MSK, we're trying to move from this old paradigm of just treating the histologies, a given histology the same, and moving to a new paradigm where each lymphoma is molecularly distinct. And so this is basically an outline of the workflow. A lot of the work that we did was originally a collaboration with Foundation Medicine, but as Dr. Arcila described, we're now doing this type of approach with our own MSK Impact platform. And this is an example of some of the data that's generated in DLBCL with some of the key genes that I just described to you. And so each patient is represented by a column, and the mutations are rows. And so you can see that each patient has a distinct mutation profile, and we're trying to figure out how we can use that mutation profile to give them individualized therapy. We have sequenced hundreds of patients here at MSK. This is showing some of the data we have for DLBCL. And what we find is that in the majority of cases, we find alterations that are either potentially actionable therapeutically or have some prognostic or predictive relevance. However, how are we bringing this into actual treatment paradigms? One of the obvious approaches is to just say, okay, if the gene's mutated and we have a drug that can target it, let's identify the patients with the mutation and put them on a trial with a drug that targets it. An example of this is the fact that there are these inactivating histone acetyltransferase mutations in DLBCL and follicular lymphoma. Those are those genes I mentioned to you previously, CREB-BP and EP300. The mutations are inactivating, and therefore it would be predicted that using a histone deacetylase inhibitor would help to convert the chromatin back to an open state and be active in this setting. So the idea is to enroll patients with these mutations on a trial with a histone deacetylase inhibitor, and Dr. Bedlevy will talk to you more about that trial, which is underway here. So this is sort of the paradigm that is most obvious and has been pursued. However, sometimes our biological rationale is too limited. And here's just one example of many where, as I mentioned to you previously, this histone methyltransferase EZH2 exhibits mutations in approximately 10% of DLBCL. And drugs have been developed that can inhibit the enzymatic activity, but they target both the mutant and the wild type enzyme. So the initial hypothesis was, okay, let's just use this drug in patients with EZH2 mutations, and it will help open up the chromatin and lead to apoptosis of the lymphoma cells. However, it's still early days, but some of the initial clinical trial data has shown that in different types of lymphoma, if you can look at the patients that respond, and pretty much most of them don't have EZH2 mutations. So what's going on here? At least this may be at least part of the explanation. There's been a class of patients identified that have mutations in another chromatin modifying complex called the SWI/SNF complex, and they now gain a dependency on normal wild type EZH2 for their survival. So the EZH2 inhibitors appear to be effective in this much larger subset of patients, as well as those that you would have predicted would be targetable in this setting. So basically, how are we going to figure this type of thing out? Because our biologic rationale is not always complete, as this example illustrates. And one of the things that we're interested in here at Sloan Kettering is really learning as much as we can from the clinical trials that we're running and clinical trials that have been run in the past. And so one of the ideas we like here is this idea of looking at exceptional responders. So this is an example from the GU Oncology group at MSK, where they had used a mTOR inhibitor, everolimus, in bladder cancer. And basically, like many trials using targeted agents in the past without any genomic selection, the drug failed to have a significant response rate. However, there was always one or two patients that would have a dramatic response. In this trial, there was one woman who had a complete response to the everolimus and remained on that therapy for many, many years. So the idea is to go identify those patients and go in and figure out which mutations they had. And that identified a specific set of mutations that she had, and then looking at the patients that had some partial activity of the drug, they had mutations in one of those genes. So we're trying to do this in the lymphoma setting now, both retrospectively and prospectively, to see in those trials that we've run with single agents without genomic biomarkers, can we find markers that identified patients who responded. This is another example where a response rate is better, but you can use the genomic profiling to kind of hone in on the patients who are most likely to respond. So this was done by the group at the NCI looking at ibrutinib in diffuse large B-cell lymphoma. As I mentioned previously, this targets the B-cell receptor signaling pathway, and what they observed was that pretty much all the patients that had response to this drug were of the ABC DLBCL subtype. Again, this is interesting, but it didn't really reveal the exact molecular basis of these responses until sequencing technology was available. And what was found is that basically any patient that had a mutation in this upstream signaling component, CD79B, which directly activates BTK, exhibited responses to ibrutinib, which directly inhibited that downstream kinase. However, if patients had mutations in downstream adapter molecules or adapter molecules in parallel pathways, ibrutinib would have no effect because the signaling was initiated downstream of the drug. So these are just some of the types of things that we're learning, and I'll summarize by saying that genomic profiling demonstrates that lymphomas are a genetically heterogeneous disease. We think that specific genomic alterations represent targets for therapeutic intervention, but as of yet, there's no FDA-approved therapy based on a genomic biomarker in lymphoma. We know that our biologic rationale can have utility, albeit sometimes limited for guiding these genomic biomarker-targeted therapies, and our ongoing efforts are to incorporate these markers into clinical trials, but as I demonstrated to you, it's going to be an iterative process. We may have a hypothesis at the beginning, but we make an observation, we have to go back and revise our hypothesis as we go along. So, thanks.